He is president of this Singapore Society of Metabolic and Bariatric Surgery. He had a lot of experience, and we call him encyclopedia of our this Pakistan Society of Bariatric Metabolic Surgery. Anybody who have got any query, he can ask, and it's just simple text Dr. Asim, and he will answer just within seconds. So it's really a great honor for me to ask Dr. Asim, and I think you will hear a great talk. Yes, over to you, Dr. Asim.
Assalamu alaikum. Thank you very much, Mas, for that very honorable introduction. I am not so honorable and not deserving of so many kind words. It's your greatness. Thank you very much, everybody, and thank you for being here to listen to what I've got to say. Mas asked me to talk about selection of patients, and I will just take my time to present on it. Just 1 minute. Share the screen. All right. So, all right. So that's myself. Selection of patients for metabolic bariatric surgery. I wish the topic was simpler. It is actually quite a simple topic, yet a very, very, very complex topic in its own. Let's just go through. I have no conflict of interest to declare. So what do we actually need to achieve to say we have been successful? Unfortunately, there is no real agreed definition of success, whether that's for weight loss, whether that's for metabolic outcomes, whether that's for mechanical complications, or whether that's based on patient-reported outcomes. So unfortunately, the literature has a lot to say about success, but there is no agreement between different institutions as to what success is really defined. And that makes it very hard then to put in how do you select your patients. This is published by somebody I know very well. This was a late paper which basically looked at dietary intervention and outcomes of diabetes. And here you can see that those patients who actually went on strict low-calorie diet in the primary healthcare in UK, this is the direct open-label cluster randomized control trial, even they were able to maintain great outcomes of their glycemic controls at 1 and 2 years. So lifestyle modification works. It works marvels if patients can lose about 15 kg of weight. Is that really success? Based on the paper, this is an excellent outcome, almost comparable. Remission in the surgical cohort being about, I think, 86%, and in the lifestyle modification above 50, about 17%, 1 year, 2 years outcome. So it is success as far as the paper is concerned, but is this success sustainable? The answer is it is very unlikely, and we have seen that from very many studies. So when we make decisions on behalf of our patients, or we guide them about making decisions of selecting procedures, there are a lot of confounders that basically confound our decision-making process. Let's go through some of this. Do remember, in the center of this is the patient. It is the patient who matters the most, and it is all about the patient. So when we make choices of treatment or selections of procedure, we need to keep in mind cost of procedure, the cultural and religious norms of the area, what kind of access to post-operative care this patient will have. You can do the world's most simplest procedure and run into a trouble which can cause a lot of problems to the patient. And you can do the most complex procedures where the patient may not have access to care and will suffer late complications. So the psychological impact of your surgery is making a great comeback, and this is now known as patient-reported outcomes. In patient-reported outcomes, you have patients who want to eat, and you do a procedure and they are not able to eat what they wanted or the way they wanted, and they're unable to meet that change. They are unable to adjust to that change. And that's not really great, because then the outcome of the procedure for them, they will never encourage their colleagues or the people that they know to go for surgical intervention. When you deal with metabolic and mechanical diseases, people want to know, will my metabolic disease become normal? In our part of the community, it is very common expectation that, oh, I've gone through surgery, my diabetes is cured, or my hypertension is cured, or my cholesterol problem is cured, and I don't need to ever check it again, and I don't need to do anything else again. What are we really looking at? What is sufficient weight loss for this patient? Is this patient doing it for cosmetic reasons? For basically loss of self-esteem? Then there is ample amount of literature to show that one needs to lose at least 70% of excess weight for that individual to perceive a change in his or her own self. And 70% excess weight loss and maintenance is quite a fair bit of issue. What are the complications of the procedures? Is that something that the patient is willing to do? And I tell patients who want and come and ask for biliopancreatic diversion, I tell them, do you have an access to toilet 3 times a day? Because every time you eat a meal, it is very likely you will need to visit the toilet. Is that something that is acceptable to you? And most of them would decline. And if that's the case, then fat-soluble vitamin absorption is severely hindered. And if they do not follow up, they may be rid of obesity, but they may die of nutritional consequences in future. How does the socioeconomic conditions of the patient influence the outcomes are some of the factors that we need to keep in mind where we can make decision or selection of procedures and patients matching easier. There's some evidence that's available in some of these aspects, while there are no evidence for the others. Now, recognizing that obesity is a disease is unfortunately far from accepted as yet. Many insurances, at least in the outside world, do not pay to cover obesity. I do not know about Pakistan if they do cover, but many parts in the world do not cover. Can the payer actually afford the cartridges? All these they do not come cheap. And if you do complex procedures like BPDS and all them, the need to take supplement for the rest of the life can be challenging. So they're getting rid of one disease, but they're putting up in another, whether you have the infrastructure for long-term care. So this brings me to the topic of what I call personalized care. What works for one person may not work for you. It may work because they align to your metabolic outcomes that you desire, but you may not be able to come up with terms for taking the supplements. Your patient may not come up with terms for paying for that procedure or for the rigorosity of follow-up for that procedure. And thus, there's always this conflict of interest that we need to deconflict. So what is important is when we talk to our patient is talk about what would work in our own circumstances. And this has to be a discussion that should be based on evidence. It's no harm even discussing that disease in the long term may resurge and require combination therapy even after surgery. Now let's take diabetes and obesity as an example here, and I will try and illustrate what we have learned. So what is the goal of metabolic surgery, or what we commonly call as diabetes surgery? It is basically preventing or delaying the onset of complications. You can prevent this by inducing remission. Does remission with or without medicines really matter? To me, no, it does not matter, as long as the patient can enjoy the same outcomes as those who go through surgery, whether they need diabetes medicines or not, but they remain in remission. I think they've done well. And there are those who we can prevent having diabetes, so we can contribute. These are largely the goals of surgery. What we do have are great tools that result in varying outcome of diabetes. So diabetes remission in those that are 35 and below is 72%, and about 70% in the 35 and above group, according to this Annals of Surgery paper published in 2015. However, you can see of the 94 studies, 89% of the BPDS at 5 years or in the long term were actually diabetes-free. When you go to RYGB, they are lesser. When you go to sleep, only 16% of patients have actually been able to maintain their remission of diabetes. So, what is the problem? We all have great tools, but we're not looking and we're not making best use of these tools. All right, the gun should not be where it is. The sausages should not be cooked in front of a heating fan. That's no way of connecting a wire, electric wire, and you cannot supposedly repair that fat tire. So there is a mismatch here between what tools we have and how we are treating these tools, using these tools. What we need to understand is that there is a natural history of diabetes, and that's why we need to adjust to where we find the patients, in which stage we find the patient, and that is what an advice as a physician, as a surgeon, we can give our patients. And we know this because we know pathophysiology of diabetes. It is reversible under the metabolic stress if it is removed. However, it goes to a stage of irreversibility because of loss of the healthy beta cells, which under stress they lose their specialized function of production of insulin and turn into what is called the null cells. And these cells do not produce insulin, and this stage is irreversible. We know of various mechanisms, and I won't waste the audience time in discussing mechanisms of remission of diabetes. If we look at large societies, these are procedures that are endorsed by these societies. Studies has recently been endorsed both by ASMBS and IFSO, which means that these experiments by the global community and experts are no longer considered experimental procedures. There is enough data for day-to-day use. These include the sleeve gastrectomy, the Roux-en-Y bypass, the one anastomosis bypass, the Sadi's bypass, and the biliopancreatic diversion and duodenal switch. We need to understand and make patients understand the differences between procedures. There are 3 different treatments for diabetes here that I have put. One is a simple restrictive procedure. The other is sort of a mixed bypass procedure. And the center one is an endoscopic procedure for mucosal ablation. So if we stratify our patients by baseline diabetes, early versus late, it made all the sense to operate on early patients. But would patients with late onset diabetes or maybe beyond 10 years benefit? They do benefit. And this is because you can bring down their doses still by improving their glycemic outcomes. You can decrease their risk of comorbidities. All costing models have shown bariatric metabolic surgery to be cost-effective in patients who basically go for bariatric surgery. And early intervention, the relapses in the metabolic problems are delayed in patients who are operated early versus rescuing those who are in the later stage, which is seen in the dark color graph here, where the remission rates are not that great. And this goes for diseases like hypertension, hyperlipidemia, But mechanical issues like obstructed sleep apnea, backache, may or may not respond to these interventions. So it only made sense, both from a cost perspective and from an intervention funding perspective, for governments to approve new onset of diabetes as a reimbursable intervention for patients with obesity and diabetes. Though when we look at the bigger data, the pre-diabetic populations actually benefit from the surgery. Now, we looked at hours, and we were able to show that even sleeve gastrectomy worked marvels up to 3 years, but beyond 3 years, there were recurrence in diabetes, right? So cost saving after 5 years in treating patients who have pre-diabetes, surgery group similar to the euglycemic group. And this cost reduction that came from the SOS study actually came from the reduction in the consumption of medications. And you can see here where surgery is involved in this dark circles. Even at 15 years, very few patients actually became diabetic. They continue to remain euglycemic, whereas those who were diabetic actually continued to progress if they were on medical therapy in the SOS study. So are there any ways to select procedures? Now, when we select procedures, there are three things. We need to look at weight loss, we need to look at the metabolic outcomes, and we need to look at the patient-reported outcomes. Unfortunately, there is no data to patient-reported outcomes. There's a lot of data on complications, metabolic outcomes, and on weight loss. So this is the Cleveland Clinic calculator that I have put here. And you can see when I enter patient details, number of medications, use of insulin, duration of diabetes, and what the control of glycemia was, you can see the long-term remission will be 60% with bypass. Long-term is about 5 years versus 25% with sleeve gastrectomy. So if your patient falls in this profile, are you really going to offer a sleeve or a bypass? If the patient is adamant to receive a sleeve, it's okay to do a sleeve, but they do need to understand that there is difference in the outcomes. There are those patients who will be challenging, those who have high risk of stomach cancer, those who are smokers, increasing risk of marginal ulcers, diseases like Crohn's disease, those on transplant who require prednisolone, those who are high risk because of their cardiac status, the super obese patients where it's difficult for the anesthetist, and overall what you need is to get them on their feet. People with other metabolic diseases like osteoporosis may do better with procedures like sleeve gastrectomy. However, the downside being that they may have reflux issues. Now, so the long-term success was 60% and 25%. What is the chance that my diabetes will relapse in the same order? The chances of relapse or early relapse after a sleeve gastrectomy is nearly 1/3 compared to less than a quarter in bypass. So 32.1 patients of the same profile will relapse in the sleeve group, and in the bypass group, only 17.8% of patients with obesity and diabetes in the early would relapse. So this is some data that's hard, and you can discuss with your patients when you select your procedure. For your interest, I've put down all the randomized controlled trials comparing sleeve versus bypass with different outcomes, showing absolutely no difference in the outcome of their glycemia and weight loss. The Stampede trial compared best medical therapy with surgery. Okay, no differences between procedures. Sleeve versus sleeve pass trial, which had a primary endpoint of percentage excess weight loss. Again, no difference between procedures. Asim, no difference. Is this data valid for the interpretation that I am doing? Unfortunately not. And why isn't it? Because the trials were never powered to show a difference between sleeve versus bypass. Even the Cleveland Clinic data is just prospective data that we are presenting. So if you look at this systematic review published in 2019 in obesity surgery, no difference in weight loss between sleeve versus Roux-en-Y bypass at 5 years, no difference in diabetes remission. But however, relapses are different. Okay. People talk about limb length variations. Generally, most of us would do anywhere between 70 to 100. If you go and do the extra long alimentary or the biliopancreatic limb, there's no difference in diabetes outcome. It does tend to increase nutritional complications of vitamin B12, vitamin A, and folic acid deficiency over time. Now let's look at one anastomosis bypass. This is comparing one anastomosis bypass with a Roux-en-Y bypass. Certainly favoring excess weight loss to be better in patients who have one anastomosis bypass. And also improved glycemic control or remission in patients with OAGB when compared to RYGB. However, do remember that these benefits of OAGB were with extended limb length of BP limb, which is about 200 centimeters and above, and not with the conventional 150 and above. So here's the data about the 150 BP limb and the RYGB, and the OAGB being 200 to 340 limbs. When we talk about late onset diabetes, whether you do a sleeve or a bypass, the outcomes are similar. There is no difference. So if the patient wants, you can tell the patient to do a sleeve. Chances of relapse differ by about 15 to 17%. So sleeve will relapse more frequently as compared to the RYGB patients, even in patients with duration of diabetes as far as 10 years. Is remission really a hard endpoint? And is that something we need to look at in diabetes? It's probably important, but I would say that if we can improve the outcomes by even 1% in glycemia, we have done much better than any medical therapy. This is the UKPDS data. It's relatively old, published in BMJ in 2000. If you improve the glycemic index by 1% of HbA1c, there is a 37% reduction in microvascular complication, 43% reduction in peripheral vascular disease, double-digit reduction in MI, stroke, heart failure, cataract, and 21% death reduction in patients with diabetes. So even 1% makes a huge difference, and to date, medical therapy fails to even achieve 1% outcome difference. Revisional metabolic surgery, on the other hand, makes a similar difference, especially if done with an intent to approve metabolic outcomes. Last but not the least, when we choose procedures, we need to be careful as to how we will and how, as a surgeon, we will have the ability to manage the unforeseen complications that would arise, whether they be technical complications or true complications like nutritional deficiencies reported in these SADI patients, including A, selenium, iron, protein malabsorption. I do find that if you do excessive length bypass procedures, they do tend to put your patient's albumin on the lower of the normal. Although they are recorded as normal, yet they are low side of normal compared to lesser malabsorptive procedures like sleeve gastrectomy. Diarrhea are the most common complication. So all in all, how then do we select our patients? First of all, as a surgeon, know your basics in bariatric surgery. Know what procedures entail. Which procedures are you comfortable managing, not only the primary surgery, but the complications, at least in the short term, arising. If you do not, then get a mentor to mentor yourself. Bring the expectations of your patients square. Unrealistic expectations only create unhappiness. If there are procedures that provide edge over the other, then employ those procedures should you be competent in those procedures. Lastly, and more importantly, ask the patients, what do you want? What is it that is important to you? Is it cosmesis? Is it just shedding the weight? Is it your metabolic problems? Are they your mechanical problems? And then when you look back into data, data will be able to tell you which procedure then suits your needs. And more importantly, for the larger community in Pakistan, it is important to collect your data and analyze how your patients respond to different procedures. I've seen that data coming from the West says a lot about sleeve gastrectomy. Unfortunately, in carbohydrate eaters like the Asian community, where people eat a lot of bread and a lot of rice, the outcomes of sleeve are fair. They're not as good as reported by the West, but not as good as I would have liked to see them, and not in the same category as weight regain. So these are nuisances that we basically need to be aware of and adjust to our patient's need. With that, I come to the end of the talk. Thank you very much. I will take any questions if there are.
Assalamu alaikum, Asim.
Walaikum salam, sir.
Excellent talk, and thank you for the review. We learned a lot from that discussion. Thank you for sharing your experience.
Thank you, sir.
Thank you, Dr. Asim. Excellent talk, and really, always it's a pleasure to learn from you. And
thank you, sir.
everybody must have learned a lot. And we'll just vary with some questions. I think maybe after 10-20 minutes